business acumen. Okay. But in regards to melanoma, families share melanoma risk factors. So sun-sensitive skin, fair-colored eyes, red hair, freckling, having a lot of moles will run in family. There are things about skin and coloring that can increase the risk for cancer all in and of themselves. But what was interesting was, so I came from an inherited genetics background before I came into melanoma. And when I came into melanoma and I started asking about family history, because that's just something I was used to doing, there was an incredible number of patients who had a family history of cancer, and not just any family cancer, but what we would consider a significant family history of cancer, 3 or more people in the family with cancer. And so when we saw this, I said, wow, this is actually different than many of the other cancer clinics we have in breast cancer, colon cancer. It's not almost 30% that have 3 or more cancers in a family. So something just felt more familial than skin color, hair color, all of those things. And around that time, there was a very interesting Norwegian twin study. And so they had, in Scandinavia, they keep a wonderful track of their medical records and their families. And so they were able to look at twins, both what we call monozygotic or dizygotic. So that means identical or fraternal twins, a huge set of twins. And they did a statistical calculation of what were the most heritable cancers between twins. And it turns out that melanoma is the most heritable cancer between twins, right? And then also prostate cancer and leukemia. And so this was coming out all around the same time, and it looked like, look, there's more to melanoma, I think, than fair skin and fair hair. So we decided to get it. So myself and a dermatologist, this was back when I was in the clinic, we decided to open up a registry. We thankfully had a very philanthropic family in Cleveland who was really interested in family, very, very strong family culture, and also had a family member with melanoma. And they were very interested to help this project along. And just for folks in the room, you have an interesting thing, something that you're really interested in and really passionate about, you can make a difference. And I'm going to show you what the Gross family did for this project and for sort of science in general. So we offered free genetic testing. There were 12 genes that were already known to be related to melanoma. There were 70 plus genes that were related to any cancers, but not known to be related to melanoma. For all these folks, we drew out a family tree. We made sure that any genetic counseling that was involved would not be at cost for the families that participated. And then we did ask our participants to just donate a couple more tubes for science of blood. And they very kindly did. So what we did was we expanded on what was known. At the time, it was said 3 or more melanomas in a person or family, that's it. And many people even said, don't try testing, because if you test, you're just going to know that their melanoma is the family, and there's nothing you're going to do to change their treatment or change anything for their family. So this was done in Ohio, less sun. So we figured there'd be fewer melanomas. So instead of what's traditionally called the rule of 3, we did the rule of 2, less sun, less melanomas. But we also wanted to look at other cancers other than melanoma. We also looked at people who were young, and we also looked at people who didn't have a family history. Maybe they were adopted, maybe they're an only child, maybe their parents were only children. But we just wanted to get as much information about who might be at risk. And then, so this, we presented about, a year ago, but it's just published this year. Lots of people involved. And what we found, so this is where it gets a little dense with the data, but let me sort of explain. So of all the people that underwent testing, 400 people underwent testing, 15% had something that ran families. Okay? That is 1 in 7. So of all the people we tested, 1 in 7 people had something that not only had to do with their cancer risk, but also their family member's cancer risk. And what we found much more from a scientific point of view, much more interesting was that last bullet there. 67% of these findings were in genes that we had not associated with melanoma before. So we said, wow, these are genes we didn't even know were associated with melanoma. Most of the time, we're not even testing for them. I remember when I started, people would come up and ask, what gene should we test for melanoma? And we'd be like, well, there's these 3 genes and these other ones that are super rare, but not a whole lot of genes. We didn't actually really know what to test. And now we know that we're testing not enough genes. Can I tell you which genes we absolutely need to test as of today? I don't, but it is wider than we thought. Okay, and so again, sort of more scientifically laid out, let me explain. So these were the reasons that people got into the trial, okay? And these are folks who actually had something run in their families. And what were the most common reasons they were tested, essentially? And the most common reasons, so the thinking at the time was you were looking for melanoma. But it turns out the 2 most common reasons why people got tested had to do with melanoma and other cancers, melanoma and breast cancer, melanoma and colon cancer. And these were the questions we weren't asking. All of our automatic notes in dermatology or oncology are, how many people in your family have melanoma? How many melanomas do you have? But in our automatic notes, there was no question about, do you have other cancers in your family? Is there breast cancer in your family? Is there colon cancer in your family? Is there thyroid cancer in your family? That's not in our automatic notes because that's not what the data we had before that. So this then is making us think that what we need to do is when we're in a clinic with all the people, we should ask these questions. And if we don't, remind us, it's not just melanoma. I also have these other cancers in my family. And so just again to say that these are the, of those 67% of genes that we didn't know had an association with melanoma before, those are all in bold here. So you can see that there are plenty for cutaneous or skin melanoma. But there's also things that we weren't expecting. We didn't know that there was such a thing as familial melanoma if it has to do with mucosal melanoma. That's the inside of your skin. So like inside the nose, inside the rectum, that type of melanoma. We didn't know. There were a couple of genes we knew that were associated with melanoma of the eye, but this was a much broader spectrum of melanoma of the eye. And then unknown primary. There are a couple more we weren't. So essentially, all the different types of melanoma we tested had some familial relationship, and there were a lot more genes that we just had never been looking for before. And so our keynote speaker also did another set from his institution, which thankfully said the same thing as ours. So totally different state, totally different type of testing. And they also found in all of their melanomas, so a bigger data set than ours, but 700 patients in this case. But 1 out of 7 or 14%, 1 out of 7 of these folks had melanoma. And this is a totally also different reason for testing. So we had these very clear criteria. Their criteria were a little bit different, but again, they got very similar. And they also found that all the different types of melanoma, skin melanoma or cutaneous, mucosal melanoma, uveal melanoma or melanoma of the eye, they all had some relationship to familial melanoma. So we're seeing that there is a reason for testing. It used to be said that there wasn't a reason for testing, and that the reason for testing means that we may find people who are at risk not only for melanoma, but for other cancers in them and also in their family members. So why do we do this? So I always like to do a little bit because not everybody knows about what happens when you find something that runs in your family. How does that help? So it helps because even if you have had melanoma and you are found to have an inherited cancer predisposition in your family, you may be at risk for another cancer, and we can look for that. So if you've had a stage 1 melanoma, you've had it all out, we really don't think that, there's a very, very tiny risk that that melanoma can spread and we're really not really worried about that, there's a chance that a person who carries something through their family may be at risk for a different cancer, breast cancer. Maybe that person should get a screening MRI or a screening mammogram earlier. So this can actually help save for the person who finds out that a cancer runs in their family, that they can actually prevent or find cancers earlier when they're less risky. We just heard Dr. Sweater talk about what happens when you find cancers earlier, at earlier stages. At that point, it's much more curable, right? So even for someone who has melanoma, this could help save lives. In family members who have never had cancer before, but find that they are a carrier, they can go through all of that proactive screening to find cancers earlier, even prevent cancers. And for people who in the family who get tested and find out they're not carriers, then they're at general population risk, and that can be very, okay. So knowledge can save lives. Knowledge is a little scary, but it can save lives. So this is a patient who participated in the registry. He asked me to, whenever I talk about the registry, please always tell his story, and I am keeping to my promise. So this is a gentleman who was diagnosed with stage 3 melanoma. He enrolled in the study. He was found to have an MSH2 mutation. So this is a mutation for something called Lynch syndrome. It increases the risk for colon cancer and sort of GI cancers. And a couple of years later, as we were doing scans for his stage 3 melanoma, we actually found pancreatic cancer. That pancreatic cancer was borderline resectable. He went through a clinical trial and it didn't shrink. We could not get that pancreatic cancer out. So at this point, it's what we call unresectable, or pretty much sort of stage 4 pancreatic cancer. For those of you who aren't familiar, that's a terminal diagnosis, and that unfortunately the survival is not super long. But because we knew he was MSH2, we put him straight on immunotherapy, because there is, for Lynch syndrome cancers, immunotherapy can work. He actually completed his immunotherapy about 1.5 years ago. He's now sort of living with pancreatic cancer. It's been 3 years. It hasn't grown. It might be not there. It just might be radiologically there, but he is thrilled, and he wants everyone to know this is how we can save lives when we diagnose something that runs in the family. All right. So just a little bit about genetic counseling and testing. If you were curious, if you were ever to ask this question and want to know more, this usually involves getting a little bit more information about testing. That's pre-test counseling. That is drawing out a family tree, figuring out what to test for, education about the testing, because there are things that you will find out you won't find out about testing. If you're eligible for testing, then it's a blood draw in order to test. Occasionally, there are other ways to do this, like blood draw. And then if there is something that runs in your family, you get lots of information that you can pass out to your family. So you don't have to just write it down and record it and figure it out how to pass it on. It is part of what genetic counseling does. Give you all that information, print it out, multiple copies, so that you can give it to your family members, and you don't have to explain. The other thing that I think is really important to know about genetic testing is that it's yes, no, and maybe. Okay, so there is something that runs in the family, nothing runs in the family for you, or there's something in between. So this is the way technology works nowadays. It's not always black and white. There is a gray. Most gray is considered negative, but just so you know, this is what happens in genetic testing. In summary, risk for melanoma and other cancers does run in families. It is good to know these things because it can potentially save a carrier's life as well as their family members' lives. And, at least what we know so far based on our work and Dr. Shushtar's work is that if 2 or more melanomas or multiple cancers plus melanoma run in a family or person, that is a really good time to ask, should I get tested? Okay. The last thing I just wanted to say is Angelina Jolie, if any of you are familiar, she is a BRCA1 carrier. Her mother died of ovarian cancer in her 40s. and she got diagnosed with breast cancer in her 40s. And I love this quote from her that, as you all know, everyone's in this group because you've been challenged in some way, shape, or form by cancer. And, you know, there's a lot of things that we cannot control, but the things that we really should not be frightened of are the things that we can control, that we can test for, that we can get help. These are thanks to my teams.
Thank you so much, Pauline. Pauline will be here for the panel, so we'll address any questions. And I just want to say, as an author on one of the original Rule of Threes paper, which probably came out a good 15 years ago, new knowledge means everything. So thanks to Drs. Funchain and Trishari and others for really looking now. It will probably be a new Rule of Twos in the guidelines for genetic screening. So very pleased to introduce Amanda Karani, who joined us again for surgical oncology leadership. And she's going to be talking about the new upfront approaches to therapy we see, particularly for nodal disease. Amanda?